they will outgrow that.
Sure.
So we don't have to worry. Their cartilage is fine in kids most of the time. There are very rare conditions that kids have problems with their cartilage. But for all practical purposes, their cartilage is robust.
To us right now saying, man, I tuned in because I want to make sure. You said if I have joint knee pain, I'm supposed to tune in. So my immediate question right now is, being totally free from knee pain, is it a real reality?
Well, I think you can go through life without long-term knee pain, just like back pain. Everyone's going to have an episode where they have an aching back, they may have an aching knee, and fortunately, most of the time that gets better with time. Few that it becomes a more chronic. I think we can manage it quite well. I think there truly is a reality that they can do the activities that they want to do and experience very little pain.
Okay, the activities they want to. Okay, right. And other people that are listening. So when you have cross training, like I like cross training, I got a trainer and all that kind of stuff, but it is murder on my knees, the deep lunges, the squats. It's very difficult. Is it a reality for a person that has joint pain to do CrossFit?
It's one exercise or one program doesn't fit all.
Okay.
So I think you need to work with your trainer and find out. There are many things in CrossFit and cross training that you probably can do. There's probably couple of things that you can't do. You try to find those things and then put them to side and do the other things. But by all means, even with arthritis, we encourage people to be active. And sometimes it's in a lower impact activity. It may not be CrossFit, but activity is important. Now, we don't really want people sitting on the couch and doing nothing. That's harmful too. The muscles are wasting. You may be gaining weight. It's important. Being fit is a big part of maintaining a healthy joint.
Well, you can understand why people, it's kind of a oxymoron, a catch-22. Hey, if you lose weight, it'll be better on your knees, but I can't move. It hurts to move, so I can't really lose the weight like I really should. So can you understand that person is saying that right now?
Oh, I hear that every day. Yeah.
So what do you say? I mean, you said get over it.
No, there's things you can do. You don't have to do CrossFit. You can do water aerobics. You can do
water aerobics. That's good. Okay.
There in the community, there's many facilities that have pools and instructors, and they can teach you how to do exercises almost weight free. I have one of my associates, orthopedic surgeons, I was just talking today about. And I asked him what he was doing this evening. He's actually teaching a class on water aerobics.
Water aerobics.
And he swears by it.
Wow. It's good stuff.
Yeah.
So again, we're here with Dr. Thomas Ross from Atlanta Medical Center, and we're talking about joint knee pain. If you have pain in your hips, pain in your knees, then we want to be able to bring you some solutions that will help you be able to get through or even overcome the pain. So one thing that you can do, you can go online and you can type in your question online. We're going to answer it here in just a moment, but we're just going to get through some of these other questions. Now, Dr. Ross, when we talk about inflammation, which is what the joint knee pain is most of the time, is it all the time?
Yeah, I believe that's all the time.
Okay. So when we talk about that inflammation, what's the quickest way for that person that's right now listening to us and saying, my knees are swollen right now? How do they reduce that inflammation?
First thing, you got to stop what's causing this. Well, try to find out what activity or what you did that created it. So once you stop that, then we got to get rid of the inflammation. And, one acronym we use is RICE, which is rest, ice, compression, elevation. So you can ice the area down. Typically, we'll recommend, in the affected joint, 15 minutes of ice on at a time. You want to protect your skin. You don't want to make it so cold that it freezes your skin.
Wow.
But ice is an excellent anti-inflammatory. So those would be the first methods.
So you say stop. I want to kind of give you a little pushback on that. For that person who is working, I just go to work, so I can't stop, going to work. Like, is that a bigger issue? Because I have a brother. He's probably looking now. What's up, Ray? He has joint knee pain, and his thing is when I work, when I come home, man, I'm floored. He works in a warehouse, so you can't stop that. How do you manage that kind of pain?
Well, shoe wear. Maybe he could have a nice cushion on his shoe.
Okay.
So that would help. Kind of acts as a shock absorber. A lot of the warehouses have concrete, and that's a
That's
pretty
right.
rough surface.
Okay.
That can help. Then we can talk about anti-inflammatories and medications. There are over-the-counter remedies.
Like what, for instance?
Well, is there glucosamine that people talk about?
Does that really work?
Fish oil.
Does the glucosamine really work?
It's weak scientific evidence on a lot of these, but on the upside, there's very little side effects from most of these compounds. And anecdotally, I have patients of mine who take the medicines, glucosamine, fish oil, and other compounds like such, and they feel better with it.
Oh.
I don't discourage them from taking it if it feels better, but
Okay.
it's not anything from a medical standpoint we can totally endorse, saying this is
Sure.
scientifically proven to help.
Sure.
Weak evidence, but it's fairly inexpensive medication, and that can be taken. It is not FDA controlled, so
Okay.
there's some questions of how much of that compound is really, what are you getting in this, and that is clearly a downside to this, but it's a very commonly used medication.
Look, so what about things like Advil or
then you're kind of going into the field of what's called anti-inflammatory or non-steroidal anti-inflammatory medications.
Uh-huh.
And Advil and Aleve are over-the-counter medications that are, and there are prescription strength such as ibuprofen, which is a higher dose ibuprofen.
like 800 milligrams?
Yeah, that's right. So
it's a lot.
800 milligram ibuprofen is just a super Advil, if you will.
Mhm.
Naproxen is a stronger Aleve. So the over-the-counter medications are the similar compounds, but a lower dose.
So for the person that that's their daily cocktail to get through the pain, is it healthy? I mean, what would you suggest for that person? Because you know they're watching us right now.
Well, clearly you need to take it within the guidelines. So you don't want to double up on, triple up on the recommended dose, because it can cause stomach problems. It can cause blood pressure problems. It can, if you have certain ailments, you may want to speak to your doctor before you take it on a regular basis.
Okay. All right. So for the people, I've got some people who text me and they said, hey, man, make sure y'all ask this question. When you have cartilage rubbing, so the rubbing of the cartilage, is that the same thing as arthritis or inflammation?
Well, cartilage always, that's what the cartilage is designed to do. Cartilage is designed to rub against each other. The cartilage is on the end of the bone. And when we're born, that cartilage is very smooth and glistening. And that's the function of it. It creates it's very low friction in the joint. And that's why people have very good mobility in their joint and they don't have swelling. It's when that cartilage starts breaking down, it has little cracks in it, it gets thinner. Then it's still rubbing against each other, but now it has higher friction and these little pieces break off. And that's when you start having the pain.
You got some models here. You got to break it down for me so I can kind of see.
Show you what a knee looks like.
Where you're at, what you mean with that.
Okay. Katie, I don't know if you can see this.
Yeah, we can see it. Yeah.
So this is a knee model, and basically I have the knee bent, and this is the end of the femur bone and the end of the tibia bone here. And on the surface, there's it's very smooth cartilage, and as the knee bends,
so the cartilage is actually on the knee.
It's on the knee. It's attached, basically adherent to the bone, and that's what the cartilage is. You ever get like a chicken bone and you break it off, and you see the end of that really smooth surface? Well, that's what cartilage is.
And so when this becomes jagged, that's what causes the rubbing.
This is a knee here this is a little extreme. This is when your bone is rubbing a bone, and now you can see what that knee looks like. So you can imagine.
Let's see, turn it this way.
You can imagine.
Oh wow, that's crazy.
When that occurs, I don't think Advil or Aleve may not relieve this problem.
Yeah.
So we went from one extreme to the other, and we can talk about this later in the day. But when you have, and we hear about this a lot, bone on bone rubbing, and this is probably that model. That's when, after you work at the end of the shift, your knee is going to get swollen, it's going to hurt, and it's going to ache, and the over-the-counter anti-inflammatories may not help that. And that's when we got to talk about other options. And we can talk later in the session about cortisone injections, gel injections,
Mm.
as a physical therapy. Even a physical therapist working with you can be helpful.
I hurt my knee once before, and I worked with a physical therapist, and they are just like almost personal trainers, man. They really get you moving.
Right. They're personal trainers with that understanding of the biomechanics of the knee. And they understand the anatomy of the knee and the physiology of the knee and understand cartilage. And it's actually a good way to segment from them into your trainer. So a lot of times when I see patients who are very active, like yourself, and likes to work out,
like I want to,
like you want to do, I'll have them see a physical therapist, 1 or 2 visits, and they can basically delineate a workout program, and then they go back to their trainer, and then they confer with their trainer, and then they can get a program that is going to be easy on their joint, and hopefully be able to maintain it. Because I think our goal here is not for you or anyone with arthritis not to be active. I think that's probably counterproductive. It's to be active at the point where you're not having pain in your joint. And over time, as you become more fit, you lose some weight, your muscles around your knee are stronger, the tone is better, then your pain is improved.
Okay.
And that's probably the most effective way to treat joint pain, because all the other things, all the other ways we're treating it, we're just kind of putting little Band-Aids on it. But by you actually creating a better environment for your knee, then that's long term, and that's the best way to take care of this early on, so we can keep you doing CrossFit, Katie.
Well, get me back into doing it like I really should. So when we talk about pain, man, how much pain is normal? Like what's normal pain, and will normal ever be pain free for the people that are listening with joint pain right now?
I don't think pain is ever normal. I mean, so pain is the body's way of protecting itself. Okay? So there's different degrees of pain. So a little ache that you take an Advil and it gets better, and you maybe put a little ice on it, I think that we can work with. But a pain where you're doing that exercise and then your colleague the next morning says, "Why are you limping around so much?" And you're having to take an Advil and maybe take another one in 4 hours.
Okay.
That's not normal pain, and I think that should be addressed, because we don't want to perpetuate that same problem and continue to wear out that joint. We need to find ways to get a better environment for that knee and let it last as long as we can, because you're born with your cartilage. Your body has no ability to create cartilage that you're born with.
Really?
Yeah. So what you're born with is what you have. Now, when you have damaged cartilage, what your body does is it creates a new cartilage that is not as resilient. So it's almost like a scar cartilage.
Oh, so wow. I never knew that. So once you lose your cartilage, you can't. Can you surgically get cartilage?
Well, there are complex procedures where you can transplant cartilage.
Because you need cartilage, right?
Of course, right. But it's a thick surface, so over time, if you manage it well, then you'll still have some left, and hopefully at the end of when we're all said and done.
So for the person that wants to make sure that they don't, maybe somebody's younger that's listening to us right now, watching us, they want to preserve their cartilage. I mean, it's going to wear, okay, but they want to preserve it. Like, what do they need to do?
Well, maintain good body weight.
Okay.
Remain active. And I think those are the most important things. Now, unfortunately, there are some genetics that play a role in this, and some people have a higher propensity to arthritis. They may say, "Oh yeah, my grandmother had it, my mother had it, and I know I'm going to be blessed with it as well."
The genes, yeah, wow, okay.
So there are some hereditary; it's passed on for genes, and but even in those situations, you just have to make the best of what you dealt with.
Yeah, I like you. Dr. Thomas Ross from Atlanta Medical Center. I like the fact, man, that you don't have a pie in the sky conversation or mentality. And I appreciate that. I've been listening very closely. So what about knees that pop or knees that crack or they grind? Is that cartilage situation we talked about?
Well, a lot of people have that, and it's usually from that kneecap we were talking about before. And some people actually put their hands on their knees and bend it back and forth, and they can
feel the cracking, yeah.
And some people even explain it like it's like Rice Krispies popping.
Right, right, yeah.
So in those situations, And that's very common. In those situations, if it's pain-free, I don't really worry about it. I don't think they should worry about it.
Okay.
I don't think they should, if they can find an activity that seems to make that worse, they should probably back down from that. But now, if it is associated with pain, I think that is another sign of wearing of cartilage or inflammation of the lining of the cartilage. Called this, there's a lining called the synovium, and that can get inflamed. And we're going back to the same term, inflammation, and that can create that sensation of that grinding,
Popping and the grinding
and the crackling.
For that person that says, you know what, I want to be able to drop it like it's hot. You ever heard that? Drop it like it's hot.
Yeah.
You know, get down. You know, you drop down like that. You know,
Yeah.
but they can't. Would that ever be a reality for them to be able to scoop down and maybe talk to a young person and just kind of stay there without their knees hurting? Is that a possibility of a reality?
Well, a lot of deep squatting can hurt, but you know what? Let's start a little bit at a time, and then maybe at the end of it they can do it. Just like conditioning. It's you know, it's a conditioning thing, and if you do some conditioning, yeah, they can do that maybe.
Okay, I got you. All right,
we can exclude that.
Get your wobble on.
That's
okay,
right.
so what about this? Is weird. My relatives and my older relatives, they would say they know when it's about to rain because their joints start hurting and they start aching. What is that?
That's real. It is real. It's basically the changes in the pressure, the atmospheric pressure called the barometric pressure.
Yeah.
And that change they can get the sensation of that. So that is a real phenomenon.
And your body just
your body can feel that change in pressure. And people with arthritis do complain about changes. Some people would like very. That's why we have a lot of people with arthritis move to Arizona. It's a nice, dry environment.
Oh, really?
Feels good. Yeah.
I never heard that. Okay, that's pretty good.
But we're stuck here in Atlanta.
Atlanta, hey, you know, there you go.
We got some humidity here.
Right, yeah, it's pretty interesting here. It's really hot here at Radio One with Dr. Thomas Ross from Atlanta Medical Center. He is a joint pain specialist, and more information. Let's just tell you now, so you can have it. You can, I believe the link is on the page. It should be on the page. You can click on it and find more information. Not right now, because we're still talking. Let me ask you this. For the person who wants to exercise and they want to maybe do CrossFit or whatever the kind of exercising is, what are the potential questions that a person should ask a physical trainer? The conversation they should have with them about, hey, listen, my knee is what it is. What questions should they ask them to make sure that trainer is right for them?
Well, I think they need to make sure that trainer's listening to them. Okay, so again, I don't think a trainer that has a one workout for everyone is the right way to go. I think that if the trainer understands a particular area that bothers you, I think they can tailor their training programs so that you can do, you can exercise and you can do those things. I would suggest after training, if you do experience swelling after a workout or training, ice the knee down, and it works as a very good anti-inflammatory.
So can people I mean, for the person that doesn't want surgery, is it realistic to say that you may have to just ice and ibuprofen and, rice with your rest, ice,
compression
and elevation for the rest of their lives?
Well, possibly.
Okay.
Now that we can,
but I appreciate that.
But we can go. If that's not working, though, then you go to the next phase of treatment.
Okay.
So we'll try that first, and then if that's the rest is not working, the ice isn't working, then we'll talk about the anti-inflammatories. Then we'll talk, if that doesn't work, we talked about physical therapy. When it becomes what I would consider more moderate arthritis, I think the others were talking about more of a mild type of arthritis. And when I mean moderate, probably your knee hurts throughout the day. Day to day, it hurts. You think about your knee pain more than you don't think about your knee pain. When you wake up in the morning, your knee is stiff. At the end of the day, your knee is swollen. That's probably what I consider a moderate pain. Then there are other things we can offer. A cortisone injection, which is basically an anti-inflammatory medicine that is injected in the knee. It's temporizing. It's not going to last forever.
It sounds like
it can be done, and it should be done on a very sparing basis. But
Okay.
That is something that can. Sometimes it's just enough to get you pain-free to get back to those activities that we were talking about. So just to do the injection so that you can get back and exercise and hopefully, if you're overweight, you can lose some of those pounds.
Oh, okay. So it's a
so
means
just
to an end, so to speak.
Absolutely.
Okay.
You said it better than me.
Yeah. Well, so what does the cortisone do to your knee, though? I mean, why would it not be something that's a little long term?
Well, it will dissolve over time. It resorbs. So it lasts for anywhere between weeks and months.
Oh.
I don't advise it on a regular basis. I don't advise it on someone who is young, who is 30, who has a very good looking, a knee that's good. I don't think that's a very good approach.
Mm-hmm.
I would advise it in someone who has more, what I would call it, end stage arthritis, or getting closer to the point that may need surgery, but they're just not quite ready for surgery. And we're just trying to bridge that time and trying to push that surgery later on in their life.
Okay. So we talked about surgery. Let's go ahead and address the big pink elephant in the room. How do you know, man, when surgery is like absolutely necessary? You've done those levels, okay? You've got the cortisone. Now you realize, hey, this is my reality. I'm gonna have to do something. How do you know when that is?
Okay. Surgery for arthritis. I usually tell my patients, you will tell me when you're ready for this. So I'll tell you have arthritis. I will go over the options with you, but I'm not going to tell you when you're ready to have a knee replacement. You'll know because it will be that, again, the bad days will outweigh your good days. You can't do the things you want. You see your colleagues doing things, you can't do those.
Mm-hmm.
You're taking medications. Now you're even thinking about taking pain medication for this. That's not a good route to go. We want to
real pain
medicines. We don't want to treat arthritis with real pain medicines. When individuals are starting to go down that course, then I think it's time for me to discuss that as an option. And there are, sometimes we'll do it simple, just what we call cleaning the knee joint out, and arthroscopy. You hear that a lot in the sports world, where 2 small incisions are made, and through that there's a camera that's put in, and we just clean the edges of the cartilage and freshen up the knee, if you will. And that can provide some relief in specific instances. And then it can go, the next phase would be either a partial knee replacement or a complete knee replacement. And this is becoming a much more common operation. As a matter of fact, I think
the partial and
a total, or what we call a complete knee replacement.
Oh.
I think there's about 600,000 of those done a year here in the United States. So it is and the predictions are for it to exponentially increase because of our young baby boomers are all really active. They're developing these symptoms, and our techniques are so much better now than they were before. That they're getting back on their feet very quickly.
Wow, man. Okay, so I got to ask about this partial knee, whole knee, but take me back to this. If you can answer this specifically, how many injections of the cortisone before you say that's it? I'm uncomfortable with doing anymore.
I think that again depends on the age.
Okay.
So for you coming in to see me, we let's say we get an X-ray of your knee. That will be part of the workup.
So this is me.
Yeah,
okay.
That's
me.
you.
Okay.
That's you. So you're coming into my office, and I know you're active. You want to remain active. We'll get an X-ray of your knee. Look, what is that? Just a plain X-ray in the office. And if it shows that there's not, it may be a little wear, but nothing major, I may offer you an injection, here or there, but I don't want to see you in the office every 3 months getting an injection. I don't think that's good for your joint. I don't think that's healthy because basically you're masking the symptoms, and so you're still wearing, you're wearing your knee out, and so it's not really protecting your knee. It's just putting a little Band-Aid on there for a while. Now, on the other hand, if I see a patient who I know has more severe arthritis, and they're at the point where they're getting close to needing a knee replacement, but they're just not quite ready, either because of their job or because of their age. They may be just a little young. Then I think at that point I'm more willing to do more cortisone injections. And a general rule is maybe once a quarter, 3 to 4 a year.
Okay, 3 to 4 years. So it seems like
that patient, in that,
it seems like to me, it seems like this is it really is a journey. And the best thing probably to do is to be proactive about this whole scenario,
absolutely.
kind of get in front of it.
Get, like we talked about before, maintain your activity, keep your weight down,
Okay.
protect your joint.
Okay.
Yeah. And then let it, and try to preserve that cartilage, because we know, again, we can't make new cartilage. Preserve what we have.
Right.
And try to push those symptoms later on in life.
But be honest with yourself about where you are. Like, don't lie to yourself and say it's not that bad, when truth is,
Right.
You really going through some serious pain every day.
That's right. So
Yeah.
you look at your knee and it's swollen, and your colleagues are telling you you're limping around. I think you should address that.
Very good. So, hey, when you have done everything you know how to do, what do you do when you've tried everything? Then what do you do?
We're back at surgery, I guess, right?
Yeah. So tell me about that, man. So that you got partial knee, whole knee. How do you know which is which? And what the heck is a partial knee? I mean, like, what, you take half the knee off, and you got to break that down for me.
Okay. Well, I think we can conceptualize a knee as in 3 compartments. So you have to hang with me here a little bit. Okay?
You can show me.
So basically, the knee here has 3 areas. This part here,
Okay.
which is what we'll call the outer part. We have this part here. It's the inner part. Actually, in between it, there's the ligaments that we hear about, the ACL.
Yeah.
Okay. And then on the front, it's the kneecap, which is here, which goes over the top.
Oh, this is the kneecap.
That's the kneecap.
Is this the patella?
I pulled back. That's the patella.
Okay.
Yes, sir. So then that comes. So those are the 3 parts of the knee.
Right.
Now we can basically replace either of those parts individually. So if just the inner part of your knee is worn, instead of taking all the good stuff away, taking the good cartilage away, that we know that's fine, and especially in someone who's younger and more active, we can just specifically replace the part that's worn.
Oh, okay. So the partial. So if it's the
partial,
patella, then you can replace.
Patella, we can just replace the patella surface and then leave the other part. And there's some advantages to that, because first of all, it's a quicker recovery. And secondly, we're maintaining all the structures in the knee, all the ligaments are maintained. Whereas when you do a complete knee replacement, you're having to remove some of the ligaments. So the partial feels more like a natural knee. It feels more like your own knee.
So so that's the partial. So when you talk about the full knee, like
the full knee is when we get this. This is when we start thinking about the full knee. We know, so there's arthritis on this part, underneath the kneecap.
Let me ask you this. Are there some foods that you can eat perhaps that causes this to accelerate?
There is a condition called gout.
Oh.
And that is a little different form. That we talked before, there are multiple forms of arthritis. So far, we've been talking mostly about osteoarthritis, and I think I break that down to just wear and tear arthritis. But gout is a condition that is caused by the foods that we eat, with the rich foods, the meats, the red wines. All that can create crystals that deposit in your knee joint. And there are people that have a higher propensity for that, and they develop this condition called gout.
I heard of gout in your foot, but I didn't know
you can have most common is gout in that big toe. Yeah, you get the stiffness in your toe.
Wow.
But this is you can have gout in all your joints. The knee is probably the second most common. And in that case, you will find that your knee will get very swollen. It will feel warm to touch. And it's painful. And that is basically diet control. There are medications for that, but get back to the first thing is diet. And that can manage most of these things.
So you're talking about full knee replacement, man. Tell me about the recovery time. I mean, you said it's not that long. Yeah. What is not that long for partial, and what is it for a full knee replacement?
I think realistically, a partial knee replacement recovery is between 4, and we're talking. I think we need to step back. I think after both of these surgeries, you're up on your feet that same day or the next day, the very latest. So,
really?
So you're not in bed to begin with. Okay, but recovery meaning that you're up functioning without any cane or crutch or walker or whatever you choose. For a partial, probably about 4 to 6 weeks, and a total about 6 to 8 weeks. but that's basically, a 90% recovery. During that
You
wait
must
for
really got to be working hard to come back
Well-
after 2 months,
that,
though.
and I tell my patient it is a combined effort, and it's a team effort. It's a team sport here, So I'll do my part, and the patients will do theirs, and with some physical therapy and some motivation, it's really a fairly easy recovery.
Let me ask you this. You said that sometimes you don't want to do a knee replacement because the person may be too young.
Correct.
What is too young, and why is there such thing as too young? If you need it, you need it, right?
Right. Well, it used to be that we would say 50 and it was an arbitrary number. 50. If you're under 50, you're not ready for a knee replacement, or if you're over, and we'll talk about it. I think that number has crept down into the 40s, but
Why is that?
well, because these are mechanical devices, so they don't last forever. So if we're hoping to get anywhere between 15, 20, maybe 30 years from an implant. So if you're 40, there's a good chance that over those
You're going to have to get another one.
have to be revised to a new one.
Oh.
Because they will. So most likely, if you do a knee replacement in someone who is their 40s, they will have at one point in their life. The trade-off is that, and that's why we only do it when the symptoms are really affecting them. Because the trade-off is that, do they really want to wait another 20 years to when it's the prime of their life that they're miserable with their knee pain? So there is a trade-off.
Is it better to have, let's say for instance, you have problems in both your knees? Is it better to have, get them both done at the same time, like get all your wisdom teeth pulled at the same time, or you just prefer, one and then the other, or how does that work?
Great question. It's controversial.
Really? Okay.
There may be some increased risks doing both of them at the same time.
Like?
Just complications from surgery.
Okay, I got you.
So
all right.
Those type of risks. We tend to do one at a time. I think that's been more of the trend. I think it's an easier recovery. I think it's hard. It's a difficult recovery to do both at the same time. And the recovery is shortened to the point where you can do it back to, get one done and 3 months later, 6 months later, get the other one done, and can still do it in a reasonable time frame. And it's probably a safer and easier course than just trying to bite it off at one time. It's a lot.
Like people like AP, Adrian Peterson, Minnesota Vikings. I mean, you tear your ACL, man, chances are you're not coming back anytime soon. But he came back, and he came back, and not only did he come back quickly, he was at the top of his game as a running back in the NFL. Now I'm wondering, like, what happened with that? That was it genetics that made him be able to do like that, or was it just that good NFL medicine that made him, what's up?
Probably a combination of good surgery and good ethics in doing and maintaining his workouts and doing physical therapy.
Okay.
And being very motivated to recovery, because every surgery you have, you really need to have that motivation. You have to have that drive to want to get better. And Adrian Peterson, I'm sure, has a tremendous drive to get back on the field, and that's probably the reason his recovery was so complete.
I'm gonna speak for that person that's listening to us right now. They're saying, "Doctor, I hear what you're saying. However, I didn't have motivation to lose weight to be able to, take some weight off my knees." Do you really realistically think that after a knee surgery, I'll have the motivation to be able to get back on my feet, like for real?
The knee surgery you won't lose weight in knee surgery, unfortunately. So you have to have that motivation, whether it's before surgery or after, but knee surgery in itself will not create the ability to lose weight, because there are many ways to lose weight without surgery. So
okay.
I don't encourage patients to have knee surgery so they can lose weight.
Okay.
I think there's a lot of ways that they can do. If that's kind of their goal, then I would rather see them lose weight ahead of time, because maybe they won't need knee surgery then.
Wow. Wow.
And their complications will be less if they lose weight, so they'll have a better recovery.
Yeah.
And they come into the surgery stronger, and I think they'll come out of it better. So I don't think that's the best way to approach it is, do my knee and then I'll lose weight. I think the better thing is just let's do this together.
Yeah. So for the person who is at the point where they need surgery, of course, money is an option. You don't work for free. I'm sure no doctor does. Does insurance cover something like this?
Yeah, insurance does cover
Really?
knee arthroplasty and hip arthroplasty.
So it's called
Arthroplasty is basically a knee replacement or hip replacement.
Okay.
Yes,
so the hip replacement. We didn't really talk about the hip, but how do you know when you gotta?
It's the same thing. It's pain, stiffness, limp. It's usually pain in the front part of your hip, in the groin area, in the crease.
Oh,
Yeah.
Okay. So is that a replaced knee?
This is actually a partially replaced knee. Yeah. So this model is a little bit better, and so this is the replacement on the inner part of the knee.
So is that what you actually put on the knee?
This is it. Yeah, this is an accurate model. So it's a metal cap. Basically, we're not removing the whole knee. We're just preparing the surface and putting a cap.
Okay.
And then same thing on the tibia.
On the bottom there. So would you ever end up putting some on this side as well, or do you sometimes?
Not in a partial.
Oh, okay. So a full knee. Oh, okay. So full, you have to do the whole thing, huh?
Let me show you a full.
This is amazing. So when I go to the airport, man, you gotta be kidding me. Are you serious?
So the full knee is with the whole cap and the.
Well, I mean, so you have to graft it to the bone?
Either you let the bone grow into it, or you can cement it onto the bone, and that's the full knee really. So now it's that nice smooth surface.
So yeah, you got to tell the people at the airport, listen, I'm RoboCop.
Well, I'll give you a card. Let them know that you have a knee replacement.
Oh, and then they'll know it like that.
They'll know.
Okay, but insurance does cover it?
Insurance covers partial knee replacements and complete knee replacements.
That's good stuff, man. So how do I know what kind of tests? And one more time, listen here with Dr. Thomas Ross from Atlanta Medical Center. For those of you who have questions and you want to submit your questions, just go online right now, type your question in, and we'll be able to answer it momentarily after we kind of get through these questions that we have, but we may answer your question here. What kind of tests do you take to be able to determine what the diagnosis is? Partial knee replacement, just inflammation, arthritis, full knee replacement?
Well, the first test is typically an x-ray, and that can be done in most physicians' offices.
Okay.
And that will be able to assess the knee joint itself.
Okay.
Sometimes we will obtain an MRI, which is a more advanced test. It's and that actually looks at the soft tissue, looks at the cartilage. But frequently we don't even need to do that. Just plain x-rays.
Okay. So if people want to get in contact with you, they want to schedule an appointment, they want you to be there. Okay, let me ask you this. Do you need to have a primary physician before they come to you?
Many insurance companies do not require that. So you can go directly to the orthopedist.
So if you have knee pain, they come directly to you.
Directly to them.
Okay.
Yes, sir.
So if they want to reach out to you, they simply do what?
Well, they can call us at our Atlanta Medical Center. They should have a call number at 404-265-DOCS.
You're the doctor. You don't know numbers. Why am I asking you? Let me do it. 404-265-DOCS. 404-265-DOCS. You're going to be giving a seminar on tomorrow night here in Atlanta at Atlanta Medical Center, which what I'm told that you actually do these on a regular basis.
Yes, we do them monthly.
Okay.
And I would love to welcome anyone out there. It's nice to be in person, and a lot of times people will want to have questions, and we can answer those just personally. If they have any questions that they want to go over, we're there. We're available.
Okay.
We'll have the models available. I'll show actually some of the instrumentation for knee replacement, and some of the interesting thing with these partial knee replacements that we're doing at Atlanta Medical Center. It's a very advanced technology. We're doing them robotically, so it's computerized.
Really?
System. Yes.
So you're not specifically putting your hands on doing it.
You still are putting your hands on it, but the robot is assisting you to make it more precise.
Oh,
And
top notch.
this is a commitment that Atlanta Medical Center has made, and it's a very expensive equipment, and
Mm.
they felt that this provides some excellent opportunities to treat these kind of conditions in a very precise manner. So we're fortunate to have that there, and I'll present that to them. We'll show them what the computer looks like,
Okay.
at least on some pictures.
Hey, man, normalize the situation, Doc. I mean, we're about to wrap things up here, but normalize it for that person who has heard us talk the whole time, but they're still feeling kind of apprehensive about the whole situation. There are a lot of people who are apprehensive. I know personally with drugs or any kind of, and certainly surgery. Do you have to be put in anesthesia when you have the surgery? I mean, how does that whole situation work? You just numb the leg and
No, most of these surgeries are done under anesthesia, and that's actually the beauty of this whole process, because we have such better techniques. First of all, the anesthesia is better tolerated, and then we also have techniques that we can locally numb up the leg even before. So when you wake up from your surgery, your leg is numb. So you have a lot. It's an easier recovery, less painful. So there's the techniques that our anesthesiologists or those folks that are putting you to sleep,
mm-hmm.
They have provided for us, makes the recovery easier.
Mm-hmm.
So this is and that's why we can get our patients up that same day. The process is got to the point where we're doing these surgeries that staying in overnight and to some point even doing these as outpatient procedures.
Oh, really?
Yes, sir.
Check you out. Okay. So again, but just talk to that person, man, who is genuinely just afraid. One thing I like about, I've got a doctor who I remember when I went to my doctor, I had a surgery. I won't say what surgery, but he normalized it so much and it made me feel comfortable. Make that person that's listening to us just feel comfortable about the whole process, because they, many times when we go through things, we feel like we're the only ones, but make that person feel comfortable with either choosing you or whoever their doctor is.
Well, dealing with arthritis, again, there's many options how to treat it. So it's a communication between the patient. It's not a strong delineation. This is what you're going to get. You're going to need A, B, or C.
Oh, it doesn't work like that.
So we're going to discuss, and just because we have surgeon in the last of our name doesn't mean that first thing we're going to recommend is surgery.
Okay.
We're going to discuss all these things, and I think it's better not to discuss all these options, and we can tailor what's right for that particular patient, and every patient is different. I'll look at an X-ray and I won't and examine a patient, and based on their needs, there may be different recommendations. So we listen to their patients, and we can make decisions, and they'll be free to interact with us and provide their input. My job is to teach them like we're doing here. Education. That's my job, is to educate what you have,
right?
Educate how we can treat this, and then you're going to feed back to me, what do you want? So don't feel afraid to go to the surgeon, to orthopedic surgeons. The first thing out of their mouth is going to say, we're going to take you to surgery,
because they're not going to do that.
I wouldn't do that.
Okay.
Right? We want to talk about all these options, and we want to exhaust those options. Now, some people may have already been that have been just waiting, and they're already at their end. And we can discuss that, so we can try these, but they may not work.
Okay.
All right. But
all right.
That won't be we'll talk about all these different options.
So this isn't on the list, but I do want you to just put a plug in, for yourself, man. Why Atlanta Medical, and why you?
Well, I've been doing knee replacements. I've been an orthopedic surgeon for 20 years.
Okay.
I work with Resurgence. We're a large orthopedic group. I work with Atlanta Medical Center. I have worked with residents who keep me educated on the newest trends as I have to learn to teach them.
Mm-hmm.
So I'm an instructor to them. So keeping up with the newest technology.
That's good stuff. Okay. So when you've been doing something for 20 years, you are clearly a pro. I've been doing radio for 25 years. Yes, I'm a pro. Dr. Ross has been doing knee surgery or joint pain, dealing with it for 20 years. And I just think that if we're going to have a real conversation about this, as we have had for this past hour, then that's exactly what, if it were for me, I would definitely use you. I don't have a joint pain doctor because I'm gonna use all the other ones first. And then, when it comes down to it, I already got my free advice. Thank you, sir.
Yep, thank you.
or I'll be giving you a copay pretty soon, either one. But I say Atlanta Medical Center is the spot for you. All right, so let's take a little time out to answer some questions. Are there questions here? Answer some questions. And if there are none here, then I think you guys are good. Again, I'm KD Bowe. This is Dr. Thomas Ross from Atlanta Medical Center. And if you want to get in contact with Dr. Ross or Atlanta Medical Center, you can call this number, 404-265-DOCS, D-O-C-S, 404-265-DOCS. You got anything else, Doc?
That's it.
We're out. Peace.